Thank you. Thank you, Malaran. Good morning, 2 minutes before 12 o'clock. Good morning. At the outset, I'd like to thank the President and the organizing committee for giving me this opportunity to do this presentation at this workshop. Now, red eye is a common condition presenting to ophthalmology clinics, and these patients may even be presenting to you, or this may be a condition that you notice in a patient who is coming to you. So I'm going to talk about the recognition of common causes of red eye and how to recognize and urgently refer patients with high-risk condition. Now, in red eye, history taking is very important because that will direct you towards the diagnosis. So you need to take a detailed history on the onset of the condition, the location, whether it is unilateral or bilateral. And the most important question is whether it is associated with pain, because pain indicates that the condition is sinister. And this other question that is important is reduced vision and halos, which generally indicates increased intraocular pressure, giving rise to corneal edema. Then photophobia, very significant in certain conditions like acute anterior uveitis. And something that is important to you, whether the patient is wearing contact lenses, because as we all know, contact lens wearers are more prone to get corneal infections. And history of trauma, and also the medical history, whether the patient is having autoimmune conditions, because certain autoimmune conditions are associated with red eye. Now, in your history, if you get something like that the patient is having a foreign body sensation, that could actually be a foreign body, could be a keratitis, or the patient may just be having conjunctivitis. Discharge generally indicates a infection like conjunctivitis, but even a corneal ulcer may be associated with a discharge. Itching is the hallmark of allergy. So if the patient is having a red eye with itching, that generally directs you towards allergy. Then burning sensation, common feature of dry eye. So lid edema generally indicates a lid lesion like stye or even conjunctivitis. And if the patient gives a history of contact with a patient with red eye, then it's quite likely to be a conjunctivitis. Now, when you assess the patient, it is important to get the visual acuity and also measure the pupil, whether the pupil is regular, whether it is reacting to light, and the size of the pupil. The regularity is important because in conditions like acute anterior uveitis, due to the adhesions between the lens and the iris, the pupil may be irregular. And in acute angle closure, the pupil may even be dilated. Whether the patient has photophobia, because when you examine the patient, you notice that the patient is very photophobic. This is, as I told you before, this is very common in a patient with acute anterior uveitis. Then look at the cornea, whether it is clear or whether it is hazy, which generally indicates corneal edema, or whether there are opacities, like in corneal ulcers. And look at the distribution of the redness. Now, if the redness is more marked around the limbus, that is circumciliary redness or circumciliary injection, generally indicates that the patient is having either acute anterior uveitis, a corneal condition, or increased intraocular pressure. The redness distributed on the bulbar conjunctiva, that is the conjunctiva covering the globe, is generally seen in conditions like episcleritis or scleritis. And in conjunctivitis, the redness is more marked in the fornices, that is the pocket between the lid and the globe. Now, we have common causes of red eye and less common causes of red eye. So the common causes of red eye would be conjunctivitis, subconjunctival hemorrhage. A patient with blepharitis can also present with red eye, as can patients with styes, And dry eye disease in certain patients can present as a red dye. Then episcleritis and ultraviolet light, conditions caused by ultraviolet light, like pingaculum and pterygium, can present as a red dye. And corneal ulcer, acute anterior uveitis, acute angle closure, scleritis, lens-induced glaucoma and trauma can present as a red dye. Now let's move on to the commonest condition that causes red dye in our setup. It is viral conjunctivitis, generally due to adenovirus. So the patient, the symptoms of acute onset, generally it presents in one eye and then it affects the other eye. Sometimes it may remain in one eye in certain patients. Now when you ask them about their discharge, it's not significant because it is just a watery discharge. And they don't have actual pain, what they have is discomfort, and they are not photophobic. And some of these patients may have symptoms of a viral infection, like mild fever and upper respiratory tract infections like a sore throat, cold. And if you ask them, they might give you a contact history of with a patient with conjunctivitis. Now, the conjunctiva is generally red, and if you look at the conjunctiva, the redness is more marked, towards the fornices, this area. If you pull the lid down, you can see that the redness is marked there, and if you invert the upper lid, you will see that the redness is marked there. Now, some patients with conjunctivitis, very severe conjunctivitis, they may have membranes on the surface of the eye as well as subconjunctival hemorrhages. So in these patients, even if the symptoms settle, their redness may go on for some time because subconjunctival hemorrhage takes a long time to go away. And in viral conjunctivitis, generally they have enlarged preauricular nodes. That is, the lymph node here is enlarged and tender, and that will help you to confirm your diagnosis. Now, viral conjunctivitis, like most viral infections, there's no specific therapy, and generally it resolves on its own, but generally it takes time, so you have to tell the patient that. So the most important thing to tell the patient is that it is contagious, it is highly contagious, and that it is important to practice proper hygiene and hand washing. And avoid contact with others, that is, if it is a child, to stay away from school, and if it is an adult, to stay away from work. Now, in your practice, it is important to be aware of a patient who could be having conjunctivitis, because like when you do biometry, especially contact biometry and contact lens fitting, you may be transmitting the infection between patients, because sometimes in the early stages, the patient may not show any symptoms and signs, but the patient may be infective. So you must remember that. Ideally, a patient should be prescribed artificial tears and should be advised not to rub the eye, because sometimes they rub and can even end up with corneal abrasions. And generally, it is advisable to ask them to use a cold compress, that is like a hot compress, to soak a towel or something in cold water and apply it over the eyes, because that helps the swelling go down and also is very soothing to the eye. Bacteria can also cause conjunctivitis. Generally, Staphylococcus aureus, epidermidis, Streptococcus pneumoniae, and Haemophilus are the common causes. Now, here also, like in viral conjunctivitis, there has to be direct contact with the infected person or infected secretions. So the onset is subacute, and the same symptoms are there, the redness and the grittiness and the burning sensation, but here the discharge is different, because here there's a discharge which is mucopurulent, And this is also bilateral, and the patient does not have photophobia or pain. Now, their discharge is persistent throughout the day because it is mucopurulent, and the conjunctival hyperemia, mild papillary reaction, and lid and conjunctival swelling may be there. So here also, because it is contagious, you have to advise the patients about proper hygiene and preventing cross-contamination by hand washing. And this also may settle without treatment, but generally these patients have to be prescribed with antibiotic drops at least for a week. Now let's move on to conjunctivitis that is non-infectious. So allergic conjunctivitis, there are two types of allergic conjunctivitis. The acute type that is associated with hay fever. Here there's acute onset of itching with swelling, chemosis, and this may settle. Here I'm talking about the chronic recurrent allergic conjunctivitis, which is the vernal keratoconjunctivitis that you see in many patients in our setup. Usually the pediatric age group and the younger patients have this. So they may have a history of atopy, that is they may have a history of asthma, eczema, or even they may have family members who are having these conditions. So now they present with severe itching and tearing, and here the discharge is watery, and this is generally bilateral. Now, if you examine the upper lid, invert the upper lid and examine this, have that there are papillae. These papillae can sometimes be very large if this is a long-standing condition. And sometimes you also notice these follicles around the limbus. So these are called Trentas dots. Now, when managing these patients, it is important to exclude that it is not a viral conjunctivitis, because the patient's itching generally indicates that it is an allergy. So these patients benefit from cold compressors, and they have to be advised to avoid whatever they are allergic to, and generally it is the dust. So they have to be requested to stay away from that. And they can be prescribed artificial tears, antihistamines, and then mast cell stabilizers like sodium chromoglycate or olapatadine, which they may have to take for some time. Now, patients with severe attacks may need treatment with topical steroids, but as you know, because this is a chronic recurrent conditions, and giving steroids frequently may precipitate steroid-induced glaucoma in these patients. So you should not, now, even if we prescribe steroids, we generally ask them to come back for follow-up, because we keep them under close surveillance, because otherwise they may use the drugs on their own and may end up with steroid-induced glaucoma and optic nerve damage. And another thing that you are supposed to advise on these patients is that when it is itching, they tend to rub their eyes. So now you may be aware about keratoconus, and that vernal keratoconjunctivitis is considered to be a precipitating factor for keratoconus, because patients with this vernal keratoconjunctivitis and other allergies frequently rub their eyes, and that it is believed that it may have an effect on developing keratoconus. Now, let's move on to another condition that causes present with red eye. This is subconjunctival hemorrhage. Now, patient is asymptomatic, and usually it is somebody who looks at the patient who gets alarmed, and the patient may present to you. So the patient may have a history of trauma, especially if it is a significant trauma, then you have to refer the patient. Now, some patients get this following a Valsalva maneuver. That is, if they strain, the intraocular pressure goes up and there's perforation of the small vessels on the subconjunctival area. And so Valsalva maneuver can happen when they strain, when they lift something heavy, or when they cough. Vigorous bout of coughing can end up with a subconjunctival hemorrhage. And it may be spontaneous in patients who are elderly and those with diabetes and hypertension, because anyway their surface subconjunctival vessels are very fragile. And the management is conservative. Takes about a week or two for this to go away, and you have to reassure the patient. Now, this other condition is something you may have to be aware about, because you may get patients referred to you for their biometry before cataract surgery. So now this, if you notice the patient having this, you have to refer the patient back for treatment, because the patient could end up with endophthalmitis after the cataract operation. So here, there's inflammation of the lid margins, and there are different types of blepharitis. One is the Staphylococcus blepharitis, and then there's seborrheic blepharitis. And so here, the patient is symptomatic, because the patient has burning sensation and foreign body sensation. The lids are inflamed, and then they have these scabs, or their lashes are sticky and greasy. And they may either lose their lashes, the lashes may fall, or the lashes may turn gray. Now, this is a chronic, long-standing condition, and the patient has to maintain the treatment over a long period, because the moment they stop, it tends to come back. So, important to tell the patient, you have to educate and counsel the patient. Then the patient should be trained how to clean the lids. So, the patient should be advised to use warm compressors and clean the lids with either a solution of dilute baby shampoo, probably with a cotton bud. And those days there were some solutions, lid cleaning solutions available in the market. I'm not sure whether they are around still. So they need to clean the lids at least twice a day. And they should be prescribed antibiotics, ointments for the lid margin. Fusidic acid would be the best, and they could be given oral antibiotics. Now, two conditions which are not significant, but which may be a concern to the patient. One is the pingeculum, and the other one is the pterygium. Now, pingeculum is an earlier version of the pterygium, because the pingeculum may progress into a pterygium. So this is due to ultraviolet light damage to the ocular surface. The problem here is the cosmetic appearance, because the patient notices this. And other thing is they get dry eye, because of this, the tear film doesn't distribute evenly on the surface of the eye, and they may have symptoms. So usually these patients are prescribed lubricants and advised to stay out of the ultraviolet light, because that can cause a pingeculum to progress into a pterygium. Now, like this pterygium here, which is involved in the visual axis, and this may definitely be distorting the cornea, because it is pulling the cornea this way. So these patients, if the patient presents with a pterygium like this patient will definitely have to undergo surgery. Now, stys and chalasia. A sty is an infection of a lash follicle, and a chalasia is an infection of a meibomian gland. So occasionally they also may present with a red dye. Conditions presenting with redness in the bulbar conjunctiva. A common benign one is episcleritis. So it is generally seen in young patients. And now episclera is the tissue under the conjunctiva. it is between the conjunctiva and the sclera, and it may become inflamed, and patients are not that symptomatic. They may just have mild discomfort. Generally, this responds to topical steroids, topical NSAIDs, and resistant cases may need systemic NSAIDs. And in some patients, this is even self-limiting. Now, it has to be differentiated from this sinister condition, which is scleritis. Now, this is symptomatic. So, now, these patients may have associated connective tissue disorders like rheumatoid arthritis or SLE. And if a patient is already on treatment and the patient presents with this, that generally indicates that the prognosis for this, that the original disorder is not good. So now this is a potentially blinding condition because this inflamed sclera can melt and thin. So this is a patient in whom the scleritis has settled, but the patient is left with thin sclera because you can see the choroid underneath this. So they are, unlike the patients with episcleritis, they are symptomatic. They have severe pain which disturbs them, their sleep. And they are also photophobic and they have tearing. So these patients need early referral so that now they need to be treated with systemic steroids like prednisolone and may need long-term treatment. Some of them respond to oral NSAIDs, and some of them, the resistant ones, may need long-term treatment with advanced immunosuppressive drugs. I'm moving on to corneal conditions which cause red dye. Microbial keratitis or corneal ulcer. So this is a corneal ulcer presenting with pus in the anterior chamber. This is a hypopyon. So trauma can precipitate a corneal infection, can give rise to a corneal infection. And people who wear contact lenses, especially if their contact lens care regime is not good, they are more prone to get a corneal ulcer. Patients who have dry eye have higher tendency than other patients because now the aqueous tears have antibacterial substances, and when the patient has dry eye, the patient lacks those substances, so they are more prone to get infections. Then patients with corneal anesthesia, either following a neurological condition or if they have an infection like herpes, because they don't notice the trauma or the pain, they are more prone to get corneal ulcers. And the other group are those whose corneas are exposed, either because they have a facial nerve palsy or they have severe proptosis. So they can get exposure keratopathy and a corneal ulcer. Now, fungal keratitis is another entity that can present with a corneal ulcer. So in our setup, we see it in manual laborers and farmers. And especially after the trauma, if somebody treats them with steroids, their condition becomes aggravated. So they need inward management with topical antifungals and oral antibiotics in certain cases. So now if you suspect that the patient is having a corneal ulcer, you need to refer the patient urgently, because urgent management with frequent topical antimicrobials, that is antibiotics or antifungals, may be needed. Because sometimes these patients may end up with a corneal graft or a keratoplasty, because either the cornea has thinned and is about to perforate, or they are not responding to the treatment. And now the final thing about microbial keratitis is viral keratitis, that is the dendritic ulcer caused by herpes simplex type 1. So it has this is stained with rose bengal, and it has this typical branching pattern. And if you give steroids, these ulcers can enlarge. So generally, these patients are treated with acyclovir ointment 5 times a day, and even oral acyclovir 400 milligrams 5 times a day can be given. Another corneal cause of red dye is a corneal foreign body. Sometimes this may, if it is a metallic one, even it is removed, it may leave a rustering behind. So a corneal foreign body has to be removed carefully, because if it is not managed, it could end up as a corneal ulcer. So removal of the foreign body, if it's iron foreign body, removal of the rustering, proper patching and antibiotics is important. So this condition, acute angle closure, is a type of acute onset glaucoma. So if we talk about the mechanism of this, is now a patient who is prone to get acute angle closure usually has what you call a shallow anterior chamber. That is the distance between their lens and the cornea is shorter than a normal person. So when the pupil is mid-dilated, it goes and blocks the anterior chamber angle so that aqueous cannot get there, and then there's a sudden increase in the intraocular pressure. So this is manifested, that the symptoms that the patient gets are due to the corneal edema, there are halos around the lights and blurred vision. And so there are intraocular pressures, because it's an acute increase, the intraocular pressures can become very, very high. And these patients need urgent intervention. So sometimes they can also present with severe headache, vomiting and nausea, because of the, that is the body's response to the very high intraocular pressure. So if you look at their cornea, they have injection around the limbus, then the cornea is not clear because of the edema, the intraocular pressures are very high, and the anterior chamber is shallow, and the pupil is vertically oval, and there's very poor response to light. So urgent intervention to reduce the intraocular pressure is necessary. Admission, and to bring the pressure down from that level, you may need to give them mannitol, intravenous Diamox, and then other anti-glaucoma drugs, topical steroids. So once the pressure is brought down, they may need to undergo a peripheral iridectomy. A peripheral iridectomy will form a connection between the anterior and the posterior chambers and allow the aqueous to flow through the peripheral iridectomy. Generally, this is done using the laser, but sometimes in patients whose cornea is severely edematous and the anterior chamber is very shallow, you may have to have surgery, do a surgical iridectomy. And the other thing to remember is, if a patient has acute angle closure in one eye, the patient is prone to get it in the other eye. So you generally do a prophylactic PI in the other eye, the eye without symptoms. Now, acute anterior uveitis or iritis or iridocyclitis is another condition that can present with as a painful red dye. So generally this is unilateral. Depending on the severity of the inflammation, the pain and the vision loss is variable. So they have this ciliary injection, and their pupils are irregular because their iris is adherent to the surface of the lens. So these patients need early referral because their inflammation has to be brought under control with frequent topical steroids, and sometimes they may even have high intraocular pressure. So they need early intervention and investigations to find out the cause for the uveitis. So if you get a patient like this, you have to refer immediately. Then about conditions that are due to hypermature cataracts. There are two types of glaucoma, the phacolytic glaucoma and the phacomorphic glaucoma. So when a cataract is very mature, two things can happen. One is the proteins can leak out of the cataract, and they can go and block the trabecular meshwork and then increase the intraocular pressure. The other way is that mature cataract can absorb water and swell and then close the trabecular meshwork. So these patients need surgical intervention, and they need to be admitted, their intraocular pressure and the eye, the inflammation control, then they need cataract surgery. Then other condition that can cause red dye is trauma. So any kind of trauma can present as a red dye. So if the patient gives a history of trauma, it is your duty to refer the patient as soon as possible. So to conclude, the red flags in a patient presenting with the red dye is the reduced visual acuity or blurred vision with photophobia and pain, and either poor or absent pupillary response, and the corneal appearance, it may be hazy or there may be opacities, and a history of trauma. So to conclude, the red dye is an important ophthalmological condition, and it is important to differentiate emergencies that need urgent attention. So therefore, good history taking and thorough examination is necessary, and you have to look out for red flag symptoms and signs. And you have to do a careful examination to come to a diagnosis. Thank you for your kind attention. I think, yeah.
Thank you, Dr. Pradeepa. The next, I would like to call Dr. K Salwin, Senior Lecturer, Faculty of Medicine, University of Kelaniya. Hope you all don't need any introduction. He will discuss with you regarding patient presenting with vision loss. Dr. Salwin, over to you.
Thank you.